This short video will walk you through the basics of clinical documentation. Especially or specifically, I'm going to discuss a progress note, since it's a note that we write every day, probably the most liable for missing data and information and mistakes. I believe this is an important topic that you need to know very well for your daily work with patient encounters. So let's get into it. So why is it important to make sure that your documentation is accurate and professional? Well, for many reasons. It's a crucial part of patient care and safe patient care, and an important tool of documentation between providers and all the staff taking care of your patients. It's also an EPA or an trustable professional activity needed for residency advancement, meaning one of the goals of residency training is to train physicians on how to accurately document the service that they provided to their patients. And if you think about it, actually documentation is associated with all the other ACGME or competencies, including the patient care, like we talked about earlier, also professionalism, and of course accurate documentation is an integral part of our profession. It's part of the system-based learning, and many functionalities of our healthcare system relies on accurate documentation, and so on. Good documentation reassures the attending that the resident knows what is going on with the patient and able to document that accurately. Remember, your note is a legal document. You might need it months or years in the future, so you really want to make sure that your notes are actually a real reflection of the patient, of the care that you're providing to your patient. And finally, reimbursement is based on what you document. So you need to give yourself and the hospital a credit for the effort and for all the care that you provided to your patients, especially in complicated patients and difficult encounters where you spend more time probably than you spent with other patients. Next, I'm just gonna discuss briefly the assessment and plan section of your progress note and how to make it better. And then I will give some examples and specifics of what the hospital is looking for in terms of physicians' accurate documentation in their progress note. So the first paragraph in the assessment and plan structure, I believe, should be a brief clinical vignette and summary of the presentation of the patient. So it should include patient age, gender, pertinent past medical history, chief complaint, pertinent symptoms, and duration of these symptoms. Some residents like to build on this paragraph as more and more information and data are gained during the patient hospitalization so that they can use it later in the discharge summary. And that's fine as far as it has all the pertinent event and important hospital calls. Then next, you start to list the problems, and the first problem should always be the most acute problem, the most serious problem, or the most recent problem. That's the first thing that you have to tackle. And I think it should include 4 components. That's how I like to think about it. The first one is what is the most likely etiology or underlying pathology of that presentation, meaning most likely diagnosis. And we need that element of commitment. And if it's not really clear and all the options are kind of have similar probability, and that's fine. Sometimes we just don't know especially in the first few days. So you can document that the exact etiology is unclear or something like that. But most of the time, if you have enough data, and you should, by history exam and lab and imaging, you should be able to come up with a most likely diagnosis. And don't write versus, because this versus that, because it doesn't really tell me exactly what's the most likely diagnosis in this situation. And then next is, why do you think that this is what you mentioned above is the most likely diagnosis? So you need to give some supportive objectives from history, from exam, from lab or imaging, like really the pertinent finding that really support your most likely diagnosis. And then you can always mention some of the other possibilities. What are the other differential diagnoses that you should think about? It's always should be on the back of your mind, just to make the reader know that you're thinking about these. And it'd be nice if you mention why they're not the most likely diagnosis. And then the fourth component is course and progression of this particular problem. Is it getting better? Is it getting worse? What's the overall assessment? What's happening with this problem overall? It's really important that you can come up with progress about that problem from all the data that you have. So these are the 4 components that you should keep in mind when you're writing the assessment. And it's kind of the same thing for the plan. I also like to think think about it in 4 components. You're gonna write the medications that you're gonna use to tackle the problem, the investigations, and any consultations, and what the recommendations are, and also the thing that you need to look for or to monitor the progress of the patient, and what are the complications that you're expecting, what are the things that anyone who's gonna come after you should look for in terms of specifically complications, specifically the most serious ones. So if you think about the assessment plan in the 4 and 4, I think it might you might. And then after that, you tackle problem number 2, the less serious or the less recent, and then problem number 3, and then the other chronic problems. And then in the end, you want to mention, what DVT prophylaxis you're using, and it's okay if you think the patient has low risk for DVT, and you can just put like encourage ambulation. Nutrition is always important, and you have to think about nutrition in every single patient and the type of diet order that you put in. And then the cause status and surrogate decision maker of the patient, and then the reason for continuous hospitalization, what the active issue, why the patient is still in the hospital, and then expected length of stay. This is really maybe more important in the HMB. We need to know if you think the patient is appropriate for observation, which by the Medicare definition is basically the patient will need only 1 or 2 nights per night in the hospital, and then they can be discharged. Or the patient meet criteria for inpatient, and they're most likely going to stay more than 2 nights. And you have to support that decision in your documentation too. But again, every progress note, it's useful to kind of tell the reader, the nurses and the staff who are reading your note, when do you expect the patient to be discharged? And then what's the functional status of the patient, and what's the discharge plan? Do you think the patient is going to go, most likely will go home, or home health, assisted living facility, and or short-term rehab, or a SNF, etc., etc. I think that helps. Also, again, the case managers, social worker, nurses who are, taking care of your patient as well, to know what to expect. And it's always good to kind of communicate that with them directly if possible. So let's take an example. I want you to pause the video and read this note, or part of a progress note, and outline 3 things that you like about it, and maybe 3 things that you dislike about it, and then we'll go into some more details in the next slide. So apart from some spelling and grammatic and punctuations issues that were fixed, in the short case summary, I would like it to include more information about the way the patient presented. That is to say, the order of onset and duration of symptoms, for example. Assessment of the clinical progress can be added to the patient's number 1 problem to give a better picture about how the patient is doing clinically. So this is regarding the clinical vignette. With number 1 problem, it's always nice to start with a uppercase letter. For the assessment section, the main diagnosis is very clear, and there is a good layout of the clinical and lab features that support the main diagnosis, which is important, and it's clear in this from that perspective. Although it's not clear whether this is the first presentation of heart failure or an exacerbation of a previous diagnosis of heart failure. And if it is an exacerbation, we would like to know what is the cause of the exacerbation. Also, this is where there should be like a statement about how the patient is progressing. Like the patient is getting better, the patient is getting worse, stable, unstable, this kind of thing. Okay, for the plan section, it's a little bit kind of disorganized and has some contradicting statements regarding diuretics therapy, which is very important part of the diagnosis. It seems that the new plan is added below at the bottom of the note, but the old plan on the top was not deleted or edited. Whenever you do copy pasting of your assessment, you must review what you copied and edit that accordingly, rather than just add new information at the bottom of the note. So be mindful about that. I think that's one of the most common issues I have seen in the most of the notes that we write. So taking all these points into consideration, you can tell that we can make the note look and read much better. So again, pause the video and read this newly edited note based on some feedback from your colleagues, and see if you really appreciate the difference between the two. So let me me walk you through an important aspect of why accurate documentation is important from the hospital reimbursement perspective. To understand that, you need to know what is DRG, MCC, and CC. So CC means or stands for complications and comorbid conditions. MCC stands for major complications and comorbid conditions. And basically, the hospitals are paid by Medicare and other major insurance companies based on what is known as DRG, or Diagnosis Related Group. A DRG will lead to higher payment to the hospital if it has a CC in it than a DRG without a CC. And a DRG with MCC will be reimbursed even higher than a DRG with CC because it implies more complicated case. So let's take the common example of heart failure, and probably you receive a query or more from documentation and billing staff asking about some clarifications about that diagnosis of heart failure, and maybe some from other common conditions like we see in the next few slides. And here's why. So let's assume that you are taking care of a patient with hypertension and chronic kidney disease who is admitted for heart failure exacerbation, and this is what was documented. So in the documentation, it's mentioned that the patient is having CHF, hypertension, and chronic renal insufficiency. That's kind of the main language or terms used in the note. And when the hospitalist bills, they're probably gonna relate to these documentation diagnoses. So it's gonna be like CHF unspecified, hypertension, and chronic renal disease. And all the three, if they were mentioned like this, basically it's a non-CC or non-complication in comorbid conditions. It doesn't really reflect the severity of the case. And that will lead to what is known as a case mix index. The case mix index is a relative index that the Medicare and other, it's mainly Medicare that use this term to kind of have a relative weight for each DRG or for each diagnosis to reflect the severity and complications of these DRGs or cases. So a case mix index or CMI of 1 indicate this is kind of an average severity illness or diagnosis. Anything above 1, the higher the CMI above 1, the more severe the case and the more complicated the case, and the lower than 1 CMI indicate less severe case. And Medicare and the government uses this as a kind of for also not just reimbursement but also for allocation of resources, so that hospitals who are taking care of more and more patients with higher and higher CMI, they should receive more support and more reimbursement because they're taking care of more sicker patients. So in this specific scenario, based on this documentation and diagnosis, the CMI will be reflected as close to 0.6 or 0.7, which also indicate that the average hospital stay for such patients should be only 2 to 3 days, and that will lead to reimbursement for something about $5,000 to $6,000. Now, with the same patients, when you get a query about they ask you for more specific and accurate documentation for the same patient, if you documented in the right way and wrote something like acute systolic or diastolic, depending on what the patient has, heart failure exacerbation with moderate bilateral perfusions, if they have that, due to hypertension and associated with chronic kidney disease stage 4. So as you see, this is more accurate, more specific documentation, and this will lead to diagnosis with more MCC and CC in it. So for example, acute systolic heart failure exacerbation is an MCC, pleural effusion is a CC, CKD with a specific stage like stage 4, which implies like an advanced CKD is a CC. So that will lead to a CMI or case mix index of 1.5, which is much higher than 0.6 or 0.7, and that will indicate that the patient should stay probably in average from about 4 to 5 days, and that ultimately should lead to reimbursement almost double of that first documentation. It would be about 13,000 to about 14,000. So as you can see, really kind of documentation can really make a lot of difference, and that's why one of the reasons why the hospital will really kind of look into the documentation by physicians to make sure that they really truly reflect the severity of the patient that they're taking care of, and I think that's very fair. I'm going to give you more examples to maybe hopefully demonstrate that better. If you get a query, probably it's going to fall under one of these common diagnoses and conditions, but there are more. But I think these are the most common one. So for example, altered status, they might ask you to clarify if you think the patient is having delirium or even better, acute encephalopathy. And if they do, document what type of acute encephalopathy you're suspecting. Is it acute metabolic, acute toxic encephalopathy due to pneumonia, for example? So basically, what's the underlying cause of the encephalopathy? And I think that's really more accurate and more scientific. Also, respiratory distress is not enough. You need to document whether you think it's acute respiratory distress, chronic respiratory distress, you think it's hypoxic respiratory distress, or hypercapnic respiratory distress, with some documentation about some of the clinical features that make you suspecting that. In addition, for example, to documentation of an O2 that's less than 90%, for example, just more data to support your documentation. And if your patient with COPD, they're on HOMO2, that's a chronic hypoxic respiratory failure. Elevated creatinine, also, if you think the patient is having AKI, document AKI as such, and also mention what do you think is the underlying cause of AKI. A lot of inpatient, they have ITN, acute tubular necrosis, as underlying cause of most of AKI. So if you're suspecting that, document that. It helps. And also, a patient with CKD stage 4 and above are expected to be sicker than, for example, patient with CKD stage 1 or 2. So document the exact stage of the CKD if your patient is having CKD. Metastatic cancer, better you document what type of cancer, the stage of the cancer, and if it's stage 4, where are the metastatic cells. And if you document something like history of cancer, that might imply that a patient is not really having active issue with cancer and they're not really severely sick, which could be not the case. Again, it depends on your particular case for sure. And then if you have a patient with high or low BMI, document specifically what stage they are in the malnutrition spectrum, if they're having obesity versus morbid obesity versus morbid obesity, and document exactly what the BMI. If they have a BMI less than 19, is suspecting some protein calorie malnutrition, you need to kind of look into what stage. Is it mild? Is it moderate? Is it severe? And the next slide, I'll share a little more details with that. Also, diabetes, we need to know if it's controlled and uncontrolled, and if there's any complication associated with it. Sepsis is also a big one. If you're suspecting that the patient is having a source of infection or a likely source of infection, in addition to positive Sears criteria, you need to document where exactly the source of the infection, and if there's any acute organ damage or acute tissue injury, you need to specify what type. Is it, for example, AKI? Is it encephalopathy? What organ is affected? That helps a lot to document, and you need that to document severe sepsis. And if the patient is hypotensive and they have been given some fluid, and they're not really responding to that, and you're, about to call ICU or considering ICU, you need to document that this patient is having refractory or they're having septic shock. So you need more data, more details really for accurate documentation of sepsis, and that's really important. Elevated INR, you can document the patient is having coagulopathy. You need to document what the underlying cause of the coagulopathy to indicate that they have a higher risk of bleeding. And lastly, it's always nice if you write possible or probable or likely or suspected rather than versus or not sure or rule out. It's just more clear, and it implies in more clarity exactly what you're thinking about. So, look into those and try to practice a better documentation, specifically to these diagnoses, but also in general. The whole idea is really just to be more accurate and more specific towards your documentation, towards the medical issue that your patient is having, to accurately reflect the patient care that you're providing. Protein calorie malnutrition may be a little bit tricky. There's a lot of evidence that these patients would benefit from dietitian consultation. So I really highly encourage you to consider consulting a dietitian for any patient with a very high or very low BMI. And whatever is written in the nutrition consult is really need to be reflected in your note. So if they have all this documentation there, it's not enough. It needs to be in your note to reflect that you really thought about that and thought about the nutrition for your patient, and also to reflect the severity of the patient, because a lot of these patients who especially have like a very high BMI, they really have a lot of expected to have more complications and more difficult to manage in some circumstances. So basically the whole idea is really just need more data. Also the data you can find in the nutrition note. You just need to talk to them and read their note and then reflect that in your documentation as well. So in these patients, you might need to check the albumin, albumin, and these are considered one factor. And for severe, for example, you need to have at least 2 or more out of this criteria to be considered as severe. So also you need to know the ideal body weight. You need to know, the degree of weight loss recently or in the last week or 1 month or 3 months. And also whether the patient is having any dysfunctional capacity or is bedridden, and what's metabolic requirement. So again, it's just a little bit more information. And again, I think it's in this patient they really benefit from getting a dietitian consultation. So keep that in mind. So in summary, I think excellent patient care should be reflected with an excellent documentation. Good clinical reasoning and medical knowledge should also be reflected with good documentation. And basically, good documentation means accurate documentation, specific documentation, and it should reflect the severity and complexity of the cases and the patient that you're taking care of, and also should be timely and always signed on the same day in a timely fashion. I hope that was useful. Thank you very much, and see you in the next video. Bye bye.